updates and announcements, and then we're off and running. We have a full jam-packed agenda. We'll try to get it uploaded into the chat in case anybody was unable to access it. But yeah, thank you. And so let's see here. Can you go back to the beginning slide? Here we go. Okay, so just a friendly reminder that this meeting is recorded and live streamed on TVW, and thank you to our partners at TVW for being here every month and making sure that this meeting is accessible and available on their format. We will also share the recording on our HCA website, which will also have the agenda. It'll have the notes from the meeting in like probably 2 to 3 weeks. It'll have all of the presentations from today's meeting. And any other resources that we might talk about. All of those materials are open to the public. They're open to the public, and they're also required under public disclosure requests as well, the recording and meeting materials. So just a reminder not to disclose any private or confidential information. Okay, next slide. Just another reminder about language and terminology. Please use person-first language, person-centered language. Examples are on the screen. Use the term substance use rather than substance abuse. Avoid using the term addict. When people forget to use these terms, obviously, we all forget, and we're all learning, and this is a place where we want to make sure everyone is comfortable and able to learn from one another. So just use gentle reminders and confirmations with one another. And then there's a resource on the screen as well. All right, next slide. And then finally, guidelines for public feedback. So we will usually allocate 5 minutes at the beginning of the meeting and 5 minutes at the end of the meeting for public feedback. And then also throughout the updates. So typically if we have somebody coming and sharing good work that's happening, after that time, after that presentation, we'll open it up for committee member feedback. And then once the committee members have had a chance to kind of weigh in, ask questions, provide input, then we would open it up for public comment briefly as well. Just if you are providing public comment, please just remember no more than 3 minutes, just so we can make sure that we have enough time in our agenda to get through everything. And then there's a note here about public comment on each agenda item, which I just covered. And then you're also able to provide feedback through email. And so we have our email address up on the screen. Feel free to reach out anytime with recommendations about the committee or other ways that you would like to contribute or questions that you may have. Okay, I think that's it for our kind of introductory statement. Real quick before we get into roll call, just want to also provide others in the room that are here at the Cherry Street Plaza an opportunity to introduce themselves so you know kind of who else is here. And so I'll pass it to my left.
All right, good morning, everybody. My name is Michelle Martinez. I am the acting SURSAC administrator. And I have had this role before, and it's good to be back. So for those of you that don't know me, again, my name is Michelle Martinez. Hi, good morning.
Hello, my name is Sarah Melfi Klein. I use she, her pronouns. I'm also with the Healthcare Authority Division of Behavioral Health and Recovery. I work on Tony's team supervising a number of our programs and initiatives coming out of State versus Lake and where there's an intersection with the criminal legal system. Pass it to Tim.
Thank you, Sarah. Tim Candela. I use he, him pronouns. I'm the Drug User Health Advisor at the Washington Department of Health inside of the office. Primarily support slew of activities at the Healthcare Authority specific to the SURSAC. I've been around since inception, providing new ministries. Good morning to everybody, and I'm looking at.
I am Rachel Downs. I'm the admin assistant that helps side of SURSAC.
Rachel, make sure that everything is running smoothly and much appreciated. And it sounds like also we have audio is cutting in and out. So thanks for the heads up. Real quick before we get into our agenda, I did just want to do a quick roll call. I know in the past we kind of oscillated between having introductions in the chat, but I think a quick roll call makes the most sense. We can go through it real quick. Senator Dingra. Okay, Senator Braun. Representative Davis.
Morning.
Good morning. Representative Burnett. Caleb Banta Green.
Happy Monday.
Yes, happy Monday. Don Julian Saucier. Sean Meyer. Alexi Orr.
Good morning.
Good morning. Amber Cope.
I'm here.
Morning, Amber. Brandy Flood. Stormy Howell.
Good morning, present.
Good morning. And Chad Enright. Chad. John Hayden.
Good morning.
Hey, good morning, John. And Nikki Lewis.
Hi, good morning.
Morning. Sherry Candelario. James Tillett. Oh, James, I saw you put your name in the chat.
Good morning.
Hey, good morning, James. Christine Lynch.
Good morning.
Morning. Sarah Gillard. Danelle Tanksley.
Hello, good morning.
Hey, good morning. Good morning. See ya, hear ya. Malika Lamont.
Present.
Morning. Addie
Morning.
Atwell.
Hi, good morning.
Kevin Ballard. Hunter McKim. And then I did see Representative Monterez. Morning.
Yes, here.
And then Representative Levitt. Okay, well, it does look like we have a quorum. I don't think there's going to be any decision points today, but in case there was, we've met the requirements for a quorum of committee members present. We're going to get into HCA announcements now, and thank you all for bearing with me as I went through that. I timed it. It took 5 minutes to do roll call, and so I figured that's not too bad. Yeah, it seemed pretty efficient. It's just great to hear everyone's voice and just make sure that we know who's here and who's representing the committee every day, or at least every day that we have a chance to meet. Okay, so HCA announcements, and I wanted to try something new where I reached out to other section managers at the within the Division of Behavioral Health and Recovery and asked them to either provide updates that I could share with the committee or even come and talk about the work that they're doing. And so just for a little bit of kind of organizational structure, the Division of Behavioral Health and Recovery within HCA has 6 different sections, and we work on everything from prevention to recovery support services, and then my section is the adult substance use and treatment section. And so we do have a guest with us today from the prevention section who has made some time after being on leave to come and just introduce themselves and then also just talk a little bit about the work happening in prevention. My hope is that at least this can kind of help educate and inform the committee and others about some of the other work that's happening within DBHR, and can also help inform our ongoing conversations about what information is going to be the most relevant and most informative for the committee as we talk about these complex issues related to individuals who use drugs and might have a substance use disorder. With that, I'll pass it over to Sarah Mariani, who is our Prevention Systems Section Manager in DBHR. Sarah, are you there?
Hello.
Thank you, Tony. Good to see everyone this morning, and thanks for the invite. I think just a quick informal opportunity to say hello. I really appreciate this, being able to bring forward some of the work that happens throughout parts of the continuum. So I'm Sarah Mariani. I'm the section manager for the Substance Use Disorder Prevention and Mental Health Promotion section here at the Division of Behavioral Health and Recovery. I've been with DBHR for a while, working in various roles in prevention, and I'm honored to be the section manager right now. With the part of the work that we do around substance use disorder and mental health is really looking at how we can build the health and wellness of individuals. So most of our work is focused on families, communities, children, youth, young adults, individuals in the communities, and doing a community-wide work to focus on how we can really look at services that happen before the need for treatment services. And what we're really trying to do is delay the onset of youth use, which we know then has a positive impact on overall health and life throughout the lifehood, as well as reducing any youth use that is happening and therefore preventing substance use disorder overall. And then looking at promoting mental health and well-being. And while we know that there's definitely still a need for treatment for those that need it and recovery, of course, our goal is to help reduce and prevent people from needing those services by getting in there early in their use pattern and early in their age. So we do that through work with state partners, with our tribal partners, and then also with our local partners, think schools, cities, community members, bless you, community members, and parents, youth, working throughout all the different schools and communities to look at how we can engage and empower youth, young adults, community members, parents, to really work in their communities for local solutions to what they identify as what needs to be addressed. In the state of Washington, we focus on statewide partnerships and collaborations to enhance the state services, as well as focusing on how we can bring data in and make sure that we're making data-informed decisions, how we can drive the resources we have, such as funding, technical assistance, training resources into those areas, schools and communities that have, according to the data, the highest level of need and the highest level of risk for substance use disorders or mental health challenges. And so in that way, we're trying to really get into those high need areas and address the risk that they have, and hopefully provide positive reinforcement and really support families and communities. We do that through local services in communities and schools. We have grants that we put out for communities and schools to strategize what they need, and then we support that with evidence-based practices so that the work that they're doing can have the greatest impact. And then we also do work focused on thinking about community norms. So how can we promote positive community norms, healthy development? We do that through public education. We do that through supporting communities for local ordinances, and overall supporting health and wellness. We have just under 100 different designated community prevention and wellness sites across the state. And in those areas, the community members and the schools work together to implement a strategic plan with services for parents, families, youth. We have 2 statewide young adult programs that focus on mental health and substance use disorder prevention. And we work with the tribes across the state for these services. One of the things that's really exciting in our services is when we've done evaluations, we've seen really significant decreases in substance use indicators. So, for example, in the community prevention and wellness sites that I mentioned, where communities and schools are working together for doing services, 73% of those sites saw significant reductions in heavy drinking of youth across the community when we looked at our student survey. And 94% had significant decreases or remain neutral across all substance use outcomes, which is really great, because one of the things we know is that when youth start using alcohol before the age of 15, they're 5 times more likely to develop a substance use disorder. And so the longer that we can keep youth from using and delay that onset, the more likely we are to prevent substance use disorder. We also have found in that initiative that we have improved school outcomes. So we've improved graduation rates, we've decreased dropout rates, and improved grades. And overall, we have found through the evaluation that we were able to delay, we have demonstrated results in delaying the onset of use between 6th and 12th graders. So in our sites where we have these services, there are less 12th graders that have started using than in areas where there are not. So we're excited about the work that we get to do. We're excited to be part of this continuum and doing our part to promote health and wellness in our state and support communities and individuals and students and youth. So thanks for a few minutes there, Tony. I'm happy to answer any questions or provide more details as needed, but I think that covers the big picture stuff.
Thanks so much, Sarah. Such amazing work happening in that area. And I know, our sections have had a chance to partner on things like the state opioid response initiatives and just always looking for other ways to coordinate and just ensure that these different systems are kind of working and coordinating together. And so if the committee, if there anything kind of piqued your interest, or if there's anything you would like more information about, or inviting Sarah or other members of the prevention section back in future meetings, just please feel free to reach out and we can kind of coordinate that and figure out what that would look like. Oh, Malika, go ahead.
Yeah, Malika, go ahead. Yeah.
In the past, we had talked about potential. This is my reach out. Anyway, sorry, because I know that I'll get busy and probably forget to reach out. But I had asked about whether or not we could hear about some of the really great work that's happening with the tribes around prevention, and it would be really great to also be able to see like a map of where activities are happening as far as like regionally throughout the state. And if we could learn more about what the assessment process is in order to be able to choose which areas you're going to make investment.
Thank you. Those are great questions. The tribes do amazing work. I'd be happy to provide details on that. And I'll let Tony, you can let us know how that works into your schedule. I just dropped into the chat a map that I had just handy. So hopefully that came through. And I can also, I'll drop a couple links to our website where you can get maps and zoom in and get them a little bit easier. Thank you for that question.
Okay, thank you.
Awesome. Thanks so much, Sarah. We had also invited Diana Cockrell, who's the section manager for prenatal through 25 behavioral health. Diana had a number of conflicts and was unable to make it, but I did want to share one big initiative that's happening in that area. It's around Washington Thriving, which supports the Children Behavioral Health Work Group, a work group that has really been kind of operating and moving forward, like kind of parallel and simultaneously with the SURSAC. And so I put a couple links about Washington Thriving into the chat. And so please take a look at that. And if you have any questions or you want more information about like the Thriving work or the Children's Behavioral Health Work Group, let us know and we can kind of coordinate that as well. And then the final, and I know we're a little bit behind schedule. I think I blame it on the tech difficulties, so it's not any of our fault. Um, but just wanted to just acknowledge real quick. I know a lot of you have been tracking this, but in case you haven't seen some of the recent news coming out of the federal administration, back on July 4th or July 24th, the executive order on ending crime and disorder in America's streets was released. I'm putting a link for that into the chat. And I'm just going to just briefly just kind of summarize where the healthcare authority is in terms of like analyzing and evaluating this. Obviously, we know that this recent executive order is raising significant concerns, especially for those working closest with impacted communities. The healthcare authority is in ongoing conversations with the governor's office and other state agencies to understand what the order could mean for Washington. At this point, we expect supplemental federal rules and guidance will be needed before any provisions can be implemented. I believe SAMHSA released something on Friday, and if anybody has the link for that readily handily, unfortunately, it didn't make it to my notes, but SAMHSA has released some follow-up guidance. But right now, there are no immediate changes to HCA programs or policy, and we understand that this drastic shift in national policy is definitely creating fear and uncertainty. While we don't yet know the full impact of the order, we are committed to doing everything we can to minimize those impacts to the individuals that we serve and the programs that we operate, and will bring more information as it becomes readily available in the future. And so I just wanted to throw that out there and acknowledge it. Unfortunately, I don't have more detailed content or information to share at this time. However, like I indicated, if there is more information as to how this could potentially impact the healthcare authorities' programs or policies, make sure and share that with the committee as it comes up. And it looks like thank you, Lisa, for putting the SAMHSA Dear Colleague letter. And then Sarah, also thanks for putting those additional links regarding the prevention work. And thanks for being here. So with that kind of puts a nice little end to, sorry for ending on such a negative note, but I just didn't want to move forward with the meeting before acknowledging that order. And with that, Blake, I know we're a little bit behind schedule, but let's go ahead and open it up for committee member announcements and statements, and maybe related to the executive order, or whatever you want to share with the rest of the group.
You bet. Thanks, Tony. And thank you, Sarah. So hi, folks. Blake Ellison. Good morning. Now is the time in the meeting where you, as committee members, can announce anything that you want to announce about events, about things that you've learned or things you want other folks to know about, and also make any general comments you want to make before we get started. So does any committee member have anything that they want to announce? Go ahead and raise your hand virtually if you do. Caleb, you're up first, and Malika. Caleb, go ahead.
Sure, just real quick. Last week there was an announcement out that the federal administration is working to schedule 7-OH, which is 7-hydroxymetragonine, which is a component related to kratom. And I'm getting a lot of questions about that. And I'll let you know that we definitely see kratoms and 7-OH sold all over the state. We have a info brief I'll put up on the line. We're going to update it later this week. We have seen one instance of, so it's sold in stores. It's sold as a tablet. It's labeled as what it is. These are sort of kind of partial opioid type products. It's not obvious that they have any real mortality risk, but they certainly are related to developing opioid use disorder, and people can be treated well with buprenorphine. So I'm getting questions about the presence of 7-hydroxymetragonine, which is definitely present in the state. Wherever you're seeing kratom, you're probably seeing that sold as well. We are not seeing it. We've seen one instance in drug checking, although there's not really a reason to think people would get it checked because it's labeled as something, even though it may or may not be that. So I think the bottom line is it's out there. We're not seeing any obvious morbidity and mortality associated with it. And I'll put a link in here to a slightly out of date from last year product materials around metragony or kratom itself, as opposed to this other component. So I don't know if others want to add anything to that, but I just want to note, I'm getting a lot of questions about it. It's out there. We're not seeing any serious problems related to it in terms of much mortality, but people can definitely develop use disorder and can be treated with buprenorphine.
All right. Thank you, Caleb. Appreciate that. Malika.
I wanted to make an announcement about Vocal Washington's International Overdose Awareness Day. It will be on the 28th of August in City Hall Park in downtown Seattle. And it will be from 11:30 until 1:30. We also will be traveling with our mural of remembrance to Thurston County's International Overdose Awareness Day the day before, and we're going to be trying to get to Mason County as well.
All right. Thank you very much. Okay. Any more committee members like to make any announcements this morning? We've got some good information in the chat on a number of items, so please check that out. All right. If there are no more,
Sorry, Blake. Yeah, just real quick. I just wanted to ask a follow-up on Caleb's comment. So, Caleb, I'm not familiar with the 7-OH. So is that something different than kratom? I know we've talked about kratom in this committee in the past, but the 7-OH I'm not familiar with. So is it something completely distinct?
I'm an epidemiologist, not a pharmacologist, but my understanding is it can both be a metabolite of metragony, which is the active ingredient in kratom, and or also can be sort of isolated and I think synthesized as a separate standalone product. So it's related to kratom or metragony, but it's a more potent form of it. And last week, Health and Human Services Secretary basically asked, I think, the FDA to look at scheduling it, because that was going to be a big response to the opioid crisis in the United States. I will tell you that is not the big thing that is going to address the opioid crisis in the United States. It's a distraction, but I can share that information with you, what we do have.
All right, thanks, Caleb. And thanks, Emily Hurio from Department of Health, for sharing the link to that FDA notice in the chat for others that are interested. And then Malika, thanks so much for bringing acknowledgement and awareness to what's happening with some of the International Overdose Awareness Day efforts in the state, and glad to hear about Vocal Washington's plans. I'm going to put in the chat real quick just some information that came out from the Healthcare Authority about IOAD. There's a partner toolkit. And then we also hope to release by the end of the month. Sarah Melfi-Klein is leading efforts for, what is it called again?
Post-overdose support toolkit for loved ones. So this is for loved ones of someone who's recently experienced an overdose. So that could be caregivers, partners, best friends, community members who are supporting after a loved one has survived an overdose. So that will be coming out soon, along with some webinars to launch it, and following behind that, hopefully a companion resource guide.
Thank you. Malika, go ahead.
Sorry, y'all. I forgot to mention that the Criminal Justice Training Commission, in collaboration with Vocal and Purpose Dignity Action, will be doing an online training for around the impacts of overdose and ways and methods for response, as well as International Overdose Awareness Day. And it will be online. You can register through the Criminal Justice Training Commission, and there will be law enforcement speaking. There will people with lived experience, as well as folks from the Recovery Navigator program in Seattle King County, and again, information from Seattle King County Public Health. So just wanted to let folks know that that's another opportunity to engage in some activities and remembrance. It will be, I believe it starts at 9 o'clock, and you can go to the Criminal Justice Training Commission for information on that.
Thank you. Appreciate that. And Rep Davis, you had something in the chat. You can read it. Did you want to make a comment on that?
Nothing really to add, just that I've just been hearing probably the last 18 to 24 months from various people somewhat randomly, not any kind of synchronized effort, but it's been popping up on my radar a lot more as of late.
Okay. Thank you. Appreciate that. Okay. And looks like we don't see any more hands from committee members. Also want to give an opportunity for the public to make any comments. If any member of the public should have a comment, please raise your hand virtually, and we'll give you that opportunity. Again, calling for public comment. Any member of the public that would like to make a comment, please go ahead and raise your hand virtually now. Okay. I don't see any hands. So with that, we'll go ahead and close that section. Tony, do you want to introduce Abby for us? Let us know what Abby's going to talk about.
Yeah, absolutely. And thanks everyone for that helpful conversation and providing those updates. Just thinking about International Overdose Awareness Day, it's just such an important event and such a great way for those that have lost somebody that close to them to honor them, remember them. And so just appreciate all the updates around that and the work that is happening. This next agenda item with Abby Stamp, we talked about this back in December. So it's been a while. It's been about 8 months since we were discussing Measure 110 in Oregon. Like what's happening around that? We know that Oregon had a period of decriminalization of simple possession, and then that was, I guess, rescinded by the legislature there. And so they went back to a kind of criminalized model of simple possession. But along with that, a lot of work that was happening. And so I hope Abby's here. I did a quick review of the attendees, and Abby, are you here?
Yep, I'm here. Good morning.
Great. Good morning. Thanks so much. And sorry we're running a little bit late. So thanks for being patient while we kind of move through the agenda. But Abby agreed and is willing to share time with us today and just kind of give us an update around some of the work that's happening in Oregon related to simple possession and diverting individuals from the criminal court system.
Great. Happy to be here. Thanks for the invitation. Good morning, everybody. So my name is Abby Stamp. My pronouns are she, her, and I began with the Oregon Health Authority in their Behavioral Health Division as the Executive Director of Measure 110 back in October of last year. So I'm still feeling like a newbie being with the State Health Authority. Before that, I spent 20 years with Multnomah County, which is where Portland is centered, and spent most of my time both in behavioral health and criminal justice policy. So it's I feel like I'm in good company. So I'm going to share my screen. I have a few slides to walk through the update of where we're at with Oregon. Can I get a thumbs up that you can see my slides? Great, thank you. All right, so I wanted to do 4 quick topics, and I think I have about 20 minutes, and I'll try to cut it short in case there's any questions or discussion. I want to give an overview of the legislation that started in 2020 with the passage of Measure 110 and bring us up to date with where we are today. I'll talk about the behavioral health resource networks, a bit on our administration and evaluation with time for questions. So a quick legislative overview. So as I'm sure everybody knows, in 2020, Measure 110 was passed, and it was called the Drug Addiction Treatment and Recovery Act. And it did a few key things. As noted, it decriminalized simple drug possession. It created a fund from cannabis tax revenue that would fund substance use services across the state. It also created a law enforcement citation and referral process, not dissimilar from the LEAD model. It really allowed law enforcement the discretion of referring folks into services and treatment when they felt that that was an appropriate intervention. It established the Oversight and Accountability Council. the OAC. The OAC still exists. It is a council of about 15 individuals, many of whom have lived experience either in the criminal justice or in behavioral health systems. And it is the oversight and accountability for all of the cannabis tax revenue that funds behavioral health resource networks. And so they not only decide funding and where the money goes, but they also oversee, the day-to-day administration when the behavioral health resource networks need some sort of change, a budget adjustment, or some other mechanism through which the grant funds might shift. And the intent of Measure 110 was establishing services for communities most impacted by the war on drugs. And I should reiterate before I move on to Senate Bill 2722 is that this is a grant program. So the cannabis tax revenue populates a fund, and that fund is distributed through a competitive grant process every 4 years. So in 2021, the state legislature used Senate Bill 722 to establish the behavioral health resource networks. And it's, we love a good acronym in state government. And so they're called the BRNs, BHRN. And basically what BRNs are, it's groups of providers in each county that use those cannabis tax funds to provide screening, assessment, treatment, housing, peers, employment support, and harm reduction for anybody who wants it. And the intent is to not use Medicaid or private insurance, but really to hone in on the individuals who are under or uninsured and the services that are not billable by Medicaid or other resources. Moving on, Senate in 2023, House Bill 2513 further clarified the roles of the BRN and the OAC. And then, as noted, 2024 brought House Bill 4002. And what 4002 did is it recriminalized drug possession. It created deflection grants. So we've got one state silo, which is the Oregon Health Authority and the Cannabis Tax Revenue and the Oversight and Accountability Council granting the cannabis tax revenue. And then you've got the Criminal Justice Commission, which is another state entity that does deflection. And deflection is, again, a lot like LEAD, where it allows each Oregon county to establish the best way when a law enforcement officer has contact with an individual with drugs on their person, whether they should be deflected to some county-specific individualized intervention. And I'm sure, like Washington, Oregon's counties are very diverse and different how they want to handle these challenges, or whether the individual would be arrested and taken into custody through a more traditional criminal legal system pathway. It also eliminated the citation process. So carte blanche drug possession is, again, a law violation. And then just a few months ago, not a few months ago, let's say 2 months ago, the Oregon legislature passed Senate Bill 610. And this has been another big shift in the origins of the Measure 110 story. The Oversight and Accountability Council, and I'll remind everybody, is primarily folks with lived experience, community members who help really drive the programming, is now going to be an advisory council. So the Oregon Health Authority will be in the decision-making seat, while the OAC will lose their decision-making power, and they will be advisory to the Oregon Health Authority when making funding decisions and where the funding decision goes, and then if there's any educational campaigns around substance use and substance use disorders. It also expands the OAC membership to include many more state and county and government aligned positions, such as the Oregon Association of Counties, the local community mental health programs, the Oregon Department of Human Services, and a couple of other state agencies will be represented as well. So why did that happen in a mere 5 years? Illicit fentanyl use exploded in Oregon. And alongside the housing crisis and the experience of public drug use, we saw crime trends shift during the pandemic. We saw incredible increases in gun violence and domestic violence, particularly, the gun violence primarily in the Portland metropolitan area, which is Multnomah, Clackamas, and Washington counties. And then the post-pandemic economic impact to Portland, where there's a lot of real estate investment and folks really wedded to the economic well-being of the city core. Portland really struggled there for a while. I think things have shifted quite a bit. I myself live in Portland. But there was a lot of political activity and demonstrations during 2020. I'm sure everybody knows it. It made the news. Lots of the news made the presidential debate of all things. And so really that swinging pendulum of criminal justice policy and around drug policy hit Oregon very hard. And this is a photo of my friend Mike, who is the former district attorney. And you will, this is an actual 4-story billboard. There was a group called People for Portland that really believed that, or told a story that the criminal justice policy and the hands-off approach to the housing crisis was the reason that we saw crime increase. And all of the research has disproved that, but this was a very, very effective political campaign. So Mike's face was up on this 4-story billboard, and this was one of several. And this was about 2 years ago that this really started taking off. Mike lost the re-election. And so the state of Oregon politics around criminal justice policy has changed dramatically, I would say, in the last 5 years.
They wiped me out for the $2,000. I know they did. They had to have.
Sorry, was that a question? I couldn't hear you. No? Okay.
Yeah, please go ahead, Abby. Thank you.
So what are the behavioral health resource networks? So we'll talk a little bit about the actual provision of services. So each of Oregon's 36 counties must have a burn that's required by statute. And I already shared it's a collection of network providers. These can be like county mental health programs and also very small nonprofits who have culturally and linguistically specific services as well. And those 6 bullets there, the screening assessments, SUD services, peer supports, housing, and harm reduction are the required elements. So in some Oregon counties like Multnomah, there are 56 providers that come together and make sure all 6 of these areas are covered. And one of our smaller counties, Jefferson County, has 2 providers. And so really it has to be individualized to the community to make sure that the services really meet the needs of their community members. As I already shared, the services shall be free, and those services can't supplant Medicaid or other resources. We have 234 providers across the state. That grant cycle just began at the beginning of July, and the grant cycle is for 4 years. A little bit about kind of how we make it all work. I run a team of 24 that are grant administrators and other supports to help make sure that both the OAC runs well and the grant administration continues to grow. Improved data collection are underway. To date, we have had quite a fair amount of scrutiny justly from the legislature and the governor because the data has been focused on encounters and the dollars spent. And so if we say, we spent $4 million last quarter on housing, that just means we got the money out the door. It doesn't mean what that housing did or how people's lives were improved. And so there has been an incredible effort over the last year to improve the strategic way that data is collected. And in this new grant cycle, we're going to be able to use a statewide data collection system that is much more focused on the person and their individual needs and wants to be able to really be more demonstrative about outcomes and impact and the return on investment rather than how much money was spent and how many people were seen. Upcoming areas of focus include integrating the burn services into a more cohesive, no wrong door. It's hard to get 56 providers to work together like a seamless one provider. And so those are some of the challenges up ahead of us. We need to relaunch the Oversight and Accountability Council with its new membership, which will be a big shift for the OAC members, and we're working pretty intensely with those folks. Have a consultant on board to help do some change management and some new group norming. We have to give a data report in 2026 of April, and preparing to do the funding allocation in 2029 differently. I would say the biggest challenge for us right now is budget. Cannabis tax revenue turns out is an incredibly volatile revenue stream. And it right now is on the decline. And so every quarter, the forecast comes out and indicates where the cannabis tax revenue is going or how it's fluctuating, and trying to manage that fluctuation. But we have a 4-year grant, makes that incredibly hard to manage. And last but not least, I think what's been really interesting in this process for me coming on board is that the grant process, as it was established before for funding the burns, was a competitive, objective grant process, just like anybody applying for a SAMHSA or a DOJ grant. Like, everybody is in there and all they can see is the information on the application. And our grant process really mirrored that. What I think we need to do moving forward, particularly with the federal shift and potential changes to Medicaid, and whether folks who don't have documentation can retain their health benefits, is that we need to look at each individual Oregon County as individuals and really look at the gaps and opportunities and really identify the best way to use these limited dollars to augment and focus on filling the gaps in each county. So it's going to take a number of years to really get us there, but that's our work moving forward. That's everything.
All right. Questions? Okay, Rep. Davis, please.
Thank you so much for the presentation. So I'm a legislator here in Washington that worked on our version of this. 2 questions. The first is, do you have, you mentioned how difficult it is to get all these disparate actors to act in unison. Do you fund like some sort of entity or program or personnel to kind of be that connective tissue between the housing and the treatment and this, that, and the other thing? You know, in Washington, we do that. It was the statewide expansion of LEAD, also known as the Recovery Navigator Program, but that's the entire purpose, is to navigate people between those disparate, you know, sort of octopus arms of the system. So that's my first question. And then the second question is, you mentioned that it's, you know, not intended to supplant Medicaid, and it's to, you know, supposed to be used for either non-Medicaid reimbursable services or non-Medicaid reimbursable populations. But my question is, you know, what in your candidate assessment, to what extent is that true? Because what we find a lot in state government is it's a lot easier to not bill Medicaid. It's so infinitely easier for providers. It's also a lot easier to stand up programs. And so, you know, our state response to this doesn't bill Medicaid at all, even though arguably the peer navigation and case management is a healthcare service and would be otherwise billable. So I guess my question is, do you feel like you're really kind of maximizing? Have you, you know, struck gold in terms of the ability to make sure that you are truly maximizing Medicaid and truly only reserving this money for things that aren't billable? Or do you find that in the rush to kind of get these things stood up quickly, the state is writing checks for things that are healthcare services and could be otherwise billable?
That's great. Thank you for your questions, Representative. To answer your first question, no. We don't have enough funding or the infrastructure to have like the convener who brings together and like blends the unique landscape that is all of the 36 burns, but we do have grant administrators. So I have 7 of them on my team, and a big area of focus is ensuring that they convene and facilitate required meetings. So the burn partners must come together and they must work together. So part of that is written into legislation. So that's incredibly helpful. But I'm trying to really work with my team to really use their influence and their relationship to do what they can to help build some of that connective tissue. And I understand that providers are providers, and you know that's not going to be the magic sauce, because we do want to make sure that we have all of our funds really focused on services, even though, you know, administration and support is a big piece of that, but with dwindling resources, continuing to focus on the service provision itself. And that's really the grant admins or the GAs, their work moving forward. And I spent the last 11 years as the executive director of the local public safety coordinating council in Multnomah County, and each Oregon has one of these mandated criminal justice leaders shall collaborate type of legislation. And that was what I did. So I brought together all of the criminal justice actors and did some real collaboration there. So I'm trying to build on some of those lessons learned to help the grant admins begin to lean in much more into that networking building. To answer your second question about Medicaid, one of the amazing things the grant administrators are at doing is reviewing budgets and expenditure reports. So we ask for data both on the grant and on the individual level, and grantees are also required to submit quarterly expenditure reports. And the grant admins go through those with a fine-tooth comb and are really clear that whenever possible, we are not billing Medicaid. Actually, part of our we're not paying for services that could otherwise be billed through Medicaid or other resources. So far it's been pretty good through the negotiations process. So after all of the grantees were awarded, then we had to really hone in on what they were going to focus on because we had a budget forecast decrease, and we had to shrink all of these 234 budgets. Folks were really knew that they needed to, pay for their peers and pay for their CADCs and pay for their clinical staff through Medicaid and other resources. And actually the conversation was, well, if if all of the CADCs are covered by Medicaid, what are we going to use our Measure 110 dollars for? So what we're talking about is, from first contact with an individual all the way up until informed consent, when an individual is engaged in the treatment would be covered by Measure 110. So we took several months, and it was a lot of work and a lot of detail to get to the bottom as often as we could to ensure that the funds are being used appropriately.
And Rep Davis, if you have a follow-up question, go ahead, and then I see you.
Yeah, just a quick follow-up. Thank you so much for the response. I think I asked my first question inartfully. I guess I didn't mean, are you forcing the various octopus arms to collaborate? I meant, are you funding somebody to, basically we talk about navigating somebody in the water between the islands, an island of treatment, an island of housing, an island of, food benefits. And though in Washington State, we did fund a little bit of treatment, a little bit of housing, the primary thing we funded was peer-led case management. That was the primary intervention. So I guess that's what I'm asking. Are you funding the personnel to navigate people between those disparate systems?
Yes, thank you. I misunderstood your question. Thank you for clarifying. Yes. When the county determines that is something that would be helpful. So as one of the service areas is peers, and people can use peers in any way they deem most helpful for their community. And many times we see in the program descriptions, peer navigation.
Okay, thank you. Malika, please.
Thank you for your presentation, Abby. So I'm putting on my director lead Washington State technical support team, and I wanted to help make a little bit of a clarification. LEAD is a brand of deflection. So recognizing that, and it's a specific model. I heard your references, and it is a method of deflection, but it has specific principles and characteristics. And in tandem, I guess, or maybe piggybacking on Rep Davis's question, actually both of those pieces, the misunderstood part and the understood part around having somebody that navigates folks between the services, a person that understands the lived experience of the individual. We also have found, though, that it is crucial to have, I guess, a ringmaster to bring all the individuals that are in a specific community that is from that community to bring all the different players to the table to help them coordinate the services that those peer case managers are going to be, working with people to navigate. And I'm just wondering, have you all thought about how that develops actually some efficiencies there, as far as like when folks are working together and on the same page? Because 7 people for a whole entire state has got to be one of the hardest jobs in the world. Yeah.
So each of the county burns, some have burn coordinators, others do not. And again, we leave it, we as a state don't want to come in and tell each county how to do their business. Because some Oregon counties are incredibly populous and others are incredibly rural, and we don't, right, we've got to let the individual counties be their own unique communities. And so, I mean, so as I said, our revenue continues to decline. So we are doing everything we can within the confines of our current funding structure to support the burns and do what it is that they do best. So some burns do have coordinators, others do not.
Okay.
And that would be a person in that community knowing the providers at a much more intimate level.
Right. Okay. Thank you.
All right, thank you. And Rep Levitt, please.
Thank you so much, and good morning, all. I have a question as a follow-up and to something that you indicated that the counties decide if something would be helpful. Who at the county makes those determinations, and under what criteria do they determine if someone needs navigational support to assist in the, from not jumping in the water, as Rep Davis discusses? You said if they deem it helpful. Who deems what helpful, and how is that established?
So the expectation is that all of the providers at the county level work together. And I understand that that's not just you say go work together and that's a beautiful thing. And so some of the burns are pretty mature. They've been working together already for 3 years. It's at that table that those leaders from each of those different organizations come together and make their unique decisions. So it's very collaborative, and the providers determine. So there is not one leader. There's not someone coming in from the actual county government or, from one particular organization making those determinations.
Okay. Any follow-up? Malika, did you have another question? You just.
Oops, sorry, I forgot to put my hand down.
No worries at all. Make sure you didn't. Okay. Any more questions? All right, Abby, thank you so much for being here and answering our questions.
Thank you.
So, yeah, thank you. I don't know, Tony, if you have any comments.
No, just appreciation.
Yeah.
I mean, I can imagine how big of a lift that was and continues to be in Oregon, and just really appreciate all the work that goes into supporting our the residents to the south and the work that's happening there, and also for Abby, for you sharing your time today. So really appreciate you being here.
All right, so next up we have Kelsey. Do you want to introduce that topic?
Oh yeah, sure. Yeah, so we try to bring periodic highlights about our Recovery Navigator program in Washington State. We've talked a lot about RNP and the work that's happening, and we have our quarterly data discussions. And so this is Kelsey Clary with Salish Behavioral Health Administrative Service Organizations coming to share an update and some outcomes related to the work that's happening in Salish for the Recovery Navigator programs there. And Kelsey, so sorry we're behind schedule, and thanks for your patience and for being flexible.
That is all right. Thank you so much for having us today. Let me just get my slides up.
Then Kelsey, do you have any, and maybe you're going to introduce them, but are there others with you today as well, or are you?
Yeah, I'm just going to do a quick intro, and then we have our project managers from the Salish region here to share more about the work that's going on in each of their counties, as well as a program participant.
Thank you so much.
So yeah, no problem. Thanks again for having us. As folks said, we're here to present on the Recovery Navigator program in the Salish region. In our region, we named this program REAL, which stands for Recovery Empowerment, Advocacy, and Linkage. So you'll be hearing folks today refer to the REAL program. Just wanted to make sure that we clarified that that is the Recovery Navigator program in our 3-county region. My name is Kelsey Clary. I'm the Outreach Program Manager with Salish BHASO. Just a quick regional overview. There are 3 counties in the Salish region, and we have 5 teams working with the REAL program in those 3 counties. Some high-level data from the last 18 months. Across these 5 teams, they had 12,777 contacts with approximately 2,448 unduplicated individuals. About 8,800 of those contacts were referral and outreach, and almost 4,000 of those were case management contacts, varying from light case management or intensive case management. And now I'm going to turn it over to the project managers from Kitsap County to share more about their program.
Good morning. My name is Frankie Brezchek. I am the project manager for the West Sound Treatment Center REAL team. And so we have law enforcement jurisdictions. We have Bremerton Police Department, Port Orchard Police Department, Paulsville Police Department, Bainbridge Island Police Department, and Kitsap County Sheriff's Office. We have 2 tribe nations that we work with, the Squamish and the Port Gamble Squamish tribes. In 2024, we had 281,420 residents. Sorry guys, it's been an early morning. We have 2 real teams. We have Agape's Unlimited team, and we have the West Sound Treatment Center team. Each team has 4 staff. We have 1 project manager, 1 care manager, and 2 recovery coaches. All of our teams come from lived experience of incarceration, unhousedness, and substance use somewhere in our past. And some of our program partners include our law enforcement, so Bremerton Police Department, Port Orchard PD, Paulsville PD, Bainbridge Island PD, and Kitsap County Sheriffs. We work with our local shelters, Salvation Army, Benedict House, and Kitsap Rescue Mission. We work side by side with Kitsap Community Resources and Housing Solutions Center. Our behavioral health partners are the BART program, Peninsula Community Health Services, Kitsap Recovery Center, and Kitsap Mental Health Services. And we work with the fire departments and the CARES teams. So we have South Kitsap Fire and Rescue and CARES, Central Kitsap Fire Rescue and CARES, Paulsville Fire Rescue and CARES, Bremerton Fire Department, Bainbridge Island Fire Department, North Kitsap Fire and Rescue. And then I'm going to hand it off to my other project manager.
Hello, everybody. Good morning. My name is Cherish Mitchell-Scott, and I am the project manager out of Agape Unlimited. I'm just going to go over some of our challenges that we have within our region. We have limited withdrawal management facilities in the region. And since we only have 4 different staff members on each team, that limits our abilities as far as staff. We also have an issue with, or not issue, but we struggle with limited beds for low barrier shelters and permanent supportive housing. So that's kind of something that we have to have some creative solutions for. One of the creative solutions is for, we partner with Grow Together, Gather Together, Grow Together, which is a transportation service that goes from door to door. They can take our folks to inpatient facilities all across Washington and in the region. We also work closely with Kitsap Community Resources and Housing Solutions for access to shelter beds. They'll go ahead and do coordinated entry and get them into those placements. So now I'm going to read a success story from one of our participants. And He said, "I would love to extend my most sincere thanks to the Real Team for their dedication and professionalism in the substance addiction disorder field of service in support of my recovery from drug addiction. At the time of my life when drug addiction clouded my rational thinking and I lost the will to live and thought I had no longer had anything to live for in this world, the team intervened at the precise moment of the lowest point of my life and convinced me that there was a better way to life. They had the ability to remove me from my current dismissal location on the floor of a trap house and entered me into an 11-day drug detoxification, then a 14-day intensive inpatient treatment for the addiction of opiates. After the successful completion of treatment, the team introduced me to a fantastic group. I have found a home away from home with others who suffer from the same stigma and that society has placed on people such as me, where we are working a recovery program. Again, I want to say thank you for all of your support. And then I am going to go ahead and hand it off to Jefferson County.
Good morning, everybody. I am Braden. I'm the project manager for the Jefferson County Real Team here at Discovery Behavioral Healthcare. So in Jefferson County, we do have very small towns, but our main city is Port Townsend. Our law enforcement jurisdictions are just Port Townsend PD and Jefferson County Sheriff's Office. In 2024, our population was just shy of 34,000 and the median age of 64. Our program does have 7 staff, me, the project manager, Sam, our care manager, and 5 additional recovery coaches. Our program partners include Jefferson Healthcare Emergency Department, OLICAP, which is also known as Olympic Community Action Programs, East Jefferson Fire Rescue Cares, Quilcene Cares, and Brennan Fire Department, and then of course our local shelter at Bayside Housing. Some challenges that we have faced in our county is that we have no withdrawal management and inpatient substance use disorder treatment facilities. We do have to travel outside of our county to be able to get those. Housing, of course, is a huge challenge, and transportation as well. Some creative solutions that we've had is our partial hospitalization program that recently opened at Discovery Behavioral Healthcare. And then also coordinating with St. Michael's Hospital in Kitsap County. They are able to get people medically cleared and transported to a withdrawal management center in Kitsap County. So that does help with our travel time. We've also been taking transportation with participants to help them feel more confident in getting to where they need to go. So one of our success stories, our participant was self-referred and started engaging with Real Program. She wasn't interested of any kind of services. She was pregnant, living out in the woods and using methamphetamines. Was not interested in change. Over time, we were able to build the relationship and introduce her to medical staff who could support her through her pregnancy. A few months after the baby was born, it was removed from custody by Child Protective Services. With a lot of encouragement and peer support from the Real Team, she made the decision to go to treatment and try to get her baby back. She is now in a much more stable position with permanent housing and a job. Her CPS case plan is set to be complete in a month. It's always nice to see those full circle success stories. We did have a participant write in a 5-page letter, which of course we love to share, but we took a little snippet from it and it said, "I have never felt so low and alone in my life, but once again, Sam on the Real Team did not let me feel that way. She did what she does best and showed up for me at my lowest, offered me a hand, and encouraged me not to give up." And I'm going to go ahead and pass it on to our Collin County teams.
Hello, everyone. My name is Alicia. I am the project manager for the Real Team here at Peninsula Behavioral Health. So just a little overview of our Collin County Real Teams. Population, we have approximately 77,600 residents. This covers over 1,700 square miles of rural and coastal terrain. This would include Port Angeles, Forks, Sequim, Nia Bay, La Push, and a lot of our smaller communities. So we work with our tribal nations, which include the Quileute tribe, Makah tribe, Ho tribe, Lower Elwha Clallam tribe, and Jamestown S'Klallam tribes. We have limited public transportation, cell service, and treatment infrastructure in our rural and frontier areas. And it is noted that we have 2 real teams. So we have the Reflections Counseling Service Group, and we have Peninsula Behavioral Health. We work side by side, cross-covering, sharing resources, and responding countywide to all of our participants. We are a peer-led outreach in the rural and tribal communities. Coordinated participant referrals, on-call coverage, and warm handoffs. We do 24/7 coverage. Our program partners include local law enforcement jurisdictions. So that would be the Port Angeles Police Department, Forks Police Department, Sequim Police Department, and the Clallam County Sheriff's Office. Community paramedics and emergency medical services for follow-up care, tribal health and social programs in Neah Bay, La Push, and here in Port Angeles. We work closely with our partners in the jails, the court systems, and our prosecutors for diversion and reentry support. We also have program partners involved in housing, medication-assisted treatment, and behavioral health providers for care coordination. I'm going to go ahead and I'm going to pass it off to my partner over from Reflections for the next slides.
Hi, everyone. I'm Stephanie Aiken. So in Clallam County, there are some challenges. We have long travel times and really difficult terrain. We have very limited withdrawal management, housing, and inpatient treatment availability. We actually only have 1 inpatient treatment facility, and it's for men. There's lots of transportation barriers for participants, depending on what part of the county that we're trying to navigate. It's difficult recruiting and retraining peers in the workforce. One, the lack of housing and just how far out it is. There is a high demand from communities for small teams covering large areas. Some of our creative solutions and successes is strong interagency collaboration and tribal engagement, consistent housing and treatment access support. Our deep community trust through peer connection has grown in the last 4 years significantly. Everyone knows that, the real team's here to support the individuals in our priority population. So some of the needs are rural aware funding models, transportation and vehicle support, peer staff development and retention, and then transitional and supportive housing for individuals with SUD.
And I would like to just read a couple letters from 2 program participants that are a couple that worked with our real team here at PBH. So it says, when I first connected with the real team, I was at the Clallam County Jail and I was headed into a 1-year sentence in prison. Knowing Mike was there for me and he was able to help my girlfriend allowed me to see that I was going to have support when I was released. After getting out of prison, I contacted Mike to get support. Mike helped me with so much. Finding housing, getting my ID and social security card, helping me find work. He walked with me through the process of getting help from DSHS, finding a doctor, and meeting my basic needs. The support I received made all the difference. With Mike's help, I was able to overcome major barriers and start building a new life for myself. And then the next one, which is from his girlfriend, says, addiction and mental health challenges had taken over my life. When I met the real team, I was overwhelmed and didn't know where to start. Mike supported me with housing, treatment, and navigating systems. Mike made sure I was able to get the things I needed: food, support, and someone to believe in me. The real program gave me strength and tools to take control of my life. I honestly couldn't have done it without them. I have an appointment with an enrollment counselor for college, and I am excited what my future holds. Thank you.
So I just want to introduce someone who was actively part of the program, and I'm going to let him tell his story because it's such a beautiful one. And I just want to introduce John Lawler.
Yeah, my name is John Lawler. About 3 years ago, I was homeless and deepened my addiction living in a tent in the woods. When I was introduced to Stephanie and her and her team helped to change my life. They got me into detox and into a 28-day treatment center. While I was in the treatment center, I heard about the Union Gospel Mission in Seattle, which I immediately joined into that program. I spent a year in their inpatient treatment program. When I completed that treatment program, I went into their internship while working at the mission and learning about God and how he could change my life. I did all the classes for my peer counseling certificate. I'm a certified state peer counselor through the state of Washington. 2 months after completing my internship, I was hired on as a case manager for the Union Gospel Mission, which is a Christian treatment facility. And I am presently working as a case manager at the Union Gospel Mission. I work in pre-stabilization. I work with the guys that first come into treatment that are detoxing, coming out of homelessness. I help to get them ready to go into the 1-year treatment facility and just help them to get stabilized and help them to understand the direction that they're taking in their life. I have to thank Stephanie. I talk to her on a regular basis. She's great people. And this program saves a lot of lives. And I'm really hoping that they can continue doing what they're doing today. Thanks a lot, guys.
Thank you so much, John.
No problem.
Really appreciate you being here and sharing that with everyone. Tony, that's all that we had for our presentation. I know things got behind schedule. I'm not sure if you wanted to do if there are any questions or anything now, but I will turn it back over to you and Blake.
Thank you, Kelsey. Appreciate that. Any questions for this group? And thank you, John. Thank you, everybody. Malika, please.
Thank you so much for your presentation and for all the hard work that you're doing in your area. I have a question related to the, actually, I'm not, how will the changes with CMS impact the hospital, the partial hospitalization program that y'all were describing? Because from what I've heard, that without the Centers for Medicaid Services funding, that the hospital won't be able to last long in y'all's regions.
Braden, I'm not sure if you have any information on that from DBH that you could share.
No, I don't really have any information. That is a different department in our area, ran by our clinical director, Angel. I do know that it is grant-based right now. I'm not sure how it's going to be funded in the future. So that's really all the information I have about it right now.
Okay. Because you guys are you're like gaining so much momentum, it would be terrible to, lose that.
Yes, definitely.
All right. Thank you, Malika. Any other questions?
Just noting that maybe our next presentation by Evan Klein about the Medicaid impacts in Washington State, maybe some of that will touch on, I don't know about that specific program, but we might glean a little bit from our upcoming presentation.
Yeah. Well, Tony, I think I don't see any more questions. I think we're ready for Evan.
Yeah, before that, just Kelsey and Cherish, Frankie, Braden, Stephanie, Alicia, and definitely John, thank you so much for your time today and for sharing some of the outcomes and the numbers of individuals that you've served and also what your barriers are. It's really helpful for the committee to hear about the barriers, the regional barriers, in addition to the successes. And so just really appreciate you being here and just being present and sharing that update with the committee. And we'll maybe have you again back next year. Okay, yeah, thanks so much, Blake. Our next presentation is on the impacts of changes in Washington, impacts of changes to Medicaid for Washington State Medicaid specifically. And I think we had Sean O'Neill noted on the agenda that was sent out, but Evan Klein is here to briefly go through some of what we know or are anticipating to see in terms of how the reconciliation bill passed on July 4th or signed on July 4th will impact Medicaid in Washington State. And so Evan, thank you so much for being here, and thank you also for being patient. Just noting for the group that our final agenda item, SURSAC engagement and SURS plan monitoring, we'll just kind of kick that to the next meeting, or we'll follow up by email. But Evan, go ahead. Is Evan here?
I think Evan is on his way over. He took the he took the opportunity with the schedule adjustment to jump into another meeting. So he is on his way within just.
I think you're talking about me, and I think I'm back.
There he is.
That is like the definition of busy, when like you're like, okay, I have 5 minutes and I'm going to jump into this other meeting real quick. Evan, thanks so much.
Yeah, thanks for having me, and apologies for being a couple of minutes late. I know that you all have had a busy agenda this morning, and I've had a couple of other issues to attend to as well. I was asked to come talk a little about impact of federal budget, the HR1 on the state Medicaid program, and kind of give a little bit of an overview of what we've been working through as an agency and with our partners throughout the executive and legislative branches over the past couple of months, and then can really kind of tease what we expect to be heavily engaged on over the next months and years as the state manages kind of reaction to and implementation of the various provisions in the federal budget. I think I only have about 20 minutes, and I know you're running a bit behind, so I'm going to go fast and maybe suggest if there are questions that I would welcome those throughout. So please feel free to stop me, but we'll otherwise kind of breeze through material. Tony, is it okay? I was going to use PowerPoint materials that are actually available online. I'm happy to share my screen though to orient folks if that works.
Yeah, that'd be great. And yeah, don't worry too much about the time. We move some things around, and so I don't want you to feel rushed, but thanks for indicating that you can take questions as we go. So Blake, if you can just kind of keep an eye out for that, that way we can kind of weave those questions throughout the presentation. But yeah, sharing the PowerPoint will be really helpful. Thanks, Evan.
Great, yeah, and I would normally pull this up on PowerPoint so I could display my screen a bit better, but I do not have the most recent version saved on my computer, and I apologize for that. So I'm gonna run off the version that we have on our agency website. I also dropped a link in the chat if folks want to jump ahead or follow along. And this is material that we've circulated very broadly outside of the agency, so it may be that you've already seen it and it's not new news. But just in terms of the federal budget, for those who hadn't been tracking as closely, the HR1, as we call it, the federal recently passed federal budget was enacted on July 4th. It contains a variety of provisions that impact multiple kind of safety net programs throughout state government. Those include Medicaid, but also food assistance and individual market coverage, kind of thinking within the human services space. We are anticipating it's going to impact hundreds of thousands of individuals that we cover under the Medicaid program. And as I noted, we're still assessing the full scope of impacts. I would anticipate with a lot of these provisions, we'll start to have a better sense of what implementation might look like. And I like to think of this as, what do we have to do? How much is it going to cost? And how long is it going to take? And we're trying to answer those questions in earnest and anticipate having some answers to those questions as part of our decision package process, which is the annual process for which we develop budget appropriations to provide to the governor's office for contemplation in the governor's budget. That usually gets rolled out in the mid to late September timeframe. And so that's the clock that the agency is working up against to try and get some initial implementation considerations on paper so that we can start to work towards the 2026 legislative session and figure out, again, exactly what do we need, how long is it going to take. In terms of the major Medicaid provisions, I'm not going to cover everything because there is a lot in the budget, and I should note there's other federal activity that's happened outside of the budget as well, including new federal guidance, new federal rules, letters from CMS regarding directives that the agency is already implementing. So there's a lot going on. There's a lot we're reacting to in real time as an agency, but here kind of focusing on the policies that are in HR 1 itself. The major ones prohibits federal payments to family planning providers. This is really a provision focused on Planned Parenthood and a restriction of federal funding going to Planned Parenthood for 1 year. Increases the frequency of eligibility redeterminations in the Medicaid program from 12 months to 6 months, imposes work requirements, restricts provider taxes and the use of state-directed payments, which are payment tools that we use in the managed care space to largely increase reimbursement rates for providers. It requires payment of cost sharing for certain individuals who are enrolled in Medicaid, and then removes some waivers related to erroneous payments, really thinking about penalties for states. All of the above really jeopardizes federal funding or restricts access. There's kind of two kind of targeted approaches that the budget took, and some of these provisions have very strict changes to eligibility criteria or changes to procedural criteria related to eligibility, which we anticipate are going to restrict enrollment in the Medicaid program, or there are some targeted provisions related specifically to federal funding. So thinking about, prohibition on funding to Planned Parenthood, some of the state-directed payment provisions as well. In terms of enrollment and funding impacts, this has admittedly been a very hard set of policies to try and model impacts to. It's been very difficult, I think, for the agency to contemplate how to model these impacts in real time. We are working on supplementing some of the numbers that you see here with state level projections. But to date, we've largely been reliant on third parties. There's a variety of consultants, national organizations, industry organizations, advocates that have been doing their best to use available data to model projected impacts, particularly looking at experience from other state tests of similar policies. The majority of the provisions are directly targeting what we would frame as the ACA kind of expansion population. So those are those adults aged 19 to 65 that Medicaid was expanded to when the Affordable Care Act was passed. For Washington, that's roughly 620,000 individuals that we cover under our Medicaid program. So a lot of the eligibility enrollment provisions and the big changes in the budget are targeting kind of that portion of our Medicaid clients. We're anticipating from some of that third-party modeling I just referenced that between 200 and 320,000 Washingtonians could lose Medicaid coverage. Some of the provisions don't take effect immediately. In fact, most of them don't, particularly the eligibility enrollment provisions. So we wouldn't anticipate to see any of these effects in 2026. But as you get into 2020, end of 2026, 2027, 2028 and beyond, again, a couple 100,000 people that we would anticipate may lose coverage. And that's just the Medicaid portion of this, right? We're not talking about SNAP. We're not talking about the individual market. So I just want to highlight there are compounding effects for a population that might be churning between the individual market and Medicaid, or might also be in need of food or housing assistance and, other state programs that could be drying up or where federal funding's being lost. And, just in terms of the funding impact, certainly starting to talk about the billions of dollars. That's spread across some of the targeted funding reductions, so changes to state-directed payments, the funding that we're going to lose for Planned Parenthood services, for example. But it's also the loss of federal funding that's supporting the enrollment and the coverage for those individuals who might lose coverage. Won't spend a ton of time here just acknowledging there's a payment prohibition on federal funds going to Planned Parenthood in the budget. We anticipate that that's a loss of around $11 million for the fiscal year for which the provision would be applicable. The Governor Ferguson's office and our agency have committed to leveraging state resources to continue to pay for these services. So as of today, there's no change in service delivery for the Medicaid program, which is great news. The provision is currently enjoined through court order. So we anticipate this is going to continue to play out in the courts, possibly going up to the Supreme Court, ruling on the constitutionality of this provision itself. So more to come there, but the top line for kind of providers is no immediate impact, and certainly for our Medicaid clients, continue to use family planning services wherever you may need to access them in the Medicaid program. Work requirements. This is one of the eligibility enrollment provisions that got, I think, the most notoriety as part of HR 1 negotiations. It requires states beginning in 2026 to institute work requirements, or they kind of call them community engagement requirements, as a new condition of Medicaid eligibility. Again, this is targeting adults aged 19 to 65, makes coverage contingent on working, training, or doing community engagement 80 hours per month. There are a number of exemptions, but generally it's focusing on that kind of roughly 600,000 person Medicaid expansion population here in Washington. Impacts, we anticipate between 1 and 200,000 individuals could lose coverage as a result. And we would suspect the majority of those who lose coverage it's occurring on procedural grounds. This is a significant burden to individuals who are already struggling to navigate eligibility systems for the state. Part of our work is to mitigate the impacts. So we're working in earnest to understand what state systems need to connect. How can we implement this policy in a way that limits the need for individuals to input their own information? Can we connect to different state systems that look at employment or higher education status, for example, so that we can automate some of the process? Can we staff up as an agency to manage some of the client outreach and community engagement that's necessary here? These are a lot of the questions that we're trying to answer. Our worry is about being able to implement on the timelines that are directed in the budget. To be frank, huge kind of burden and IT system lift to manage compliance, and something that we anticipate being very difficult on a time frame to comply by the end of 2026. There is the ability for states to apply for a waiver by December 31st. That could extend implementation to December 31st of 2028, so a 2-year extension. What we don't know is how willing the federal government will be to approving those waivers, and if they do approve waivers, for how long. So, it could be for 6 months, right? Here's just a list of the exemptions. There are a number of exemptions that are included in here. I'm not going to go through them, but just noting that there are some portions of the population that would not have to meet those work requirements to remain enrolled in Medicaid. As I mentioned, another enrollment provision is around increasing the frequency of eligibility redeterminations from 6 months or from 12 months to 6 months. Yeah. This also takes effect in December of 2026. Oh, I see.
Evan, real quick, I had a quick question on the previous slide about the preclusions. Individuals with a substance use disorder or whom are actively engaged in treatment are exempted, right?
Yes, that is my understanding. I think we don't have all. I should clarify, we don't have all of the exemptions listed up here. These are just some of the major categories. I think there are a couple of exemptions related to treatment if you're in active treatment, and substance use disorder treatment is on there. So don't have that categorized on this slide. The one caveat to all of these is we have no, these are individual line items that are listed in HR 1 in the federal budget itself with no supplemental guidance at this point. So we are awaiting guidance and rulemaking from CMS. There is an obligation in the federal budget for that to be completed by June of 2026. But as you can recall from the last slide, implementation is required by December of 2026. So we are hoping we will get guidance before well before June of next year. In the absence of that, we're working a bit in the dark because, again, these are individual line items with no detail as to what does it mean to be an active substance use treatment, for example. No, I see the question in the chat again. Yeah, no definitions, no explanatory documents from CMS at this point.
Thanks, Evan.
Yeah, and I think, the general reaction from states around the country is kind of a wait and see approach, trying to do our best to acknowledge at a macro level, right? There are going to be system changes and things that we need to implement, but for specific business requirements, as we would kind of frame it for the agency, exactly what does an exemption mean? What information would need to be input into a system for us to determine that you've met an exemption and don't therefore have to meet the work requirements? We have no details, and states around the country don't. So hoping that the federal government will be flexible, particularly with the waiver provisions, in allowing states to delay implementation as long as possible, because it's going to take a long time to understand exactly what it is that we are implementing. But yeah, great questions. Won't spend much time here. Again, just speeding up the timeframes for which individuals need to redetermine their eligibility. So come back in, input their information, engage with state systems. Obviously, every additional touch point with the state creates more complexity for our clients. And we would anticipate there's a small portion of the population, but a portion of the population that needs a lot of active management with their enrollment files that could lose coverage as a result of kind of this procedural burden. State-directed payments and provider taxes. So these are provisions that are focused very heavily on federal payment for services. We, as a state, leverage state-directed payments and provider taxes in a variety of ways. On the provider tax side, the federal budget prohibits new provider taxes and ramps down existing provider taxes from 6 to 3.5% of net revenue by 0.5% beginning in 2028. So again, we're not going to see the full effects of this until the out years, but we are prohibited from implementing new provider taxes. For those who might have been tracking this past legislative session, there was kind of a Medicaid access program bill that passed. It was a covered lives assessment. It was directing the healthcare authority to apply with CMS for a new provider tax to help fund increases in Medicaid reimbursement rates. Some of those were in the behavioral health space as well. And we're kind of enjoined from implementing as a result of the federal budget really unable to engage with the federal government to implement new provider taxes in that space. It also prohibits new state-directed payments. So state-directed payments, again, are payment provisions we use in Medicaid managed care to increase Medicaid reimbursement, largely for providers and hospitals. The state-directed payment provisions in the budget don't impact provider reimbursement. So I guess the one silver lining is some of the state-directed payments that the state legislature has implemented over the past couple of years for primary care and behavioral health services in particular will be able to be retained. But it does restrict the level of our state-directed payments for hospitals. And the largest of those is our hospital safety net assessment, which was just increased beginning in 2024. And this will require rollback of that increase beginning in 2028. We anticipate that it will have an impact of around the safety net assessment, around $1.3 billion. There's another payment program that supports the University of Washington and Harborview. That's around $200 million per year, and kind of all told, looking at a $1.5 billion annual decrease in funding going to hospital services. Obviously, this is on the facility side. It's for hospitals. It's not kind of directly in the substance use or behavioral health space per se, but we know that these are facilities that are providing a lot of those services. These are supplemental payments to providers that have a higher volume of Medicare or Medicaid clientele. It's a huge mechanism that we use as a state to get reimbursement out to facilities, and so something that we're going to have to revisit as those payments start to wind down. Again, it starts in 2028. You won't feel the full effect of this as a state, or we won't for a couple of years thereafter. I'm going to breeze through a couple other provisions, then maybe pause for questions. But cost sharing requirements, again, this is focused on the Medicaid expansion population. So it's looking at the expansion population and then only those over 100% of the federal poverty level. So it's this about 72,000 individuals who may face cost sharing obligations. There's a lot of ambiguity in the federal budget, so we don't exactly know how this is going to have to be implemented, but something that we're tracking. Not going to get into the details on the good faith waiver provisions, but effectively it allows CMS to penalize states that might be making excess Medicaid payments, where in the past, a lot of the engagement with CMS when there was an excess Medicaid payment was around mitigation and compliance. How can they work with us to manage our systems and manage our programs better? Don't know what the impact of this will be in totality, and it doesn't take effect until October of 2029, but it's kind of a veiled threat about the potential of penalties and taking away the ability for CMS to waive those penalties. This is the last one, just kind of going to focus on around rural health funding. So some of you, I would imagine, have heard that there was a $50 billion pot of funds that was put in the budget. This was put in HR1 right at the end. It was part of the negotiations to get it through the Senate at the federal level. It's $10 billion annually to go out to states from 2026 to 2030. States have to apply for this funding, but it can be used by states to support rural health transformation projects. There's a number of focuses articulated in the federal budget. We have another presentation with a lot of detail on kind of what the direction is, what we know and what we don't know related to the federal fund. But it's an application-based pool of funding, and HCA is actively working on an application. We've been working in conjunction with partners at the Department of Health and the governor's office. We anticipate a lot of external engagement occurring, starting up here in earnest in the next probably week or two, because the timelines to support an application are very abrupt. We know that the federal government will have to approve or deny all applications from states before the end of the calendar year in order for states to participate. It's a one-time application for those 5 years of funding. We are hearing rumors that applications could be due as early as kind of early fall, like late September. We don't know if that's true. We're waiting on a notice of funding opportunity from the federal government. But what this is, it is an opportunity for the state to pursue some funding that it can distribute to rural communities and providers that serve rural communities. There's a broad use of those funds, but it's thinking about investing in technology, assisting rural communities, paying providers, broadening access, workforce recruitment and retention, et cetera. We anticipate there will be components of the state's plan that focus on behavioral health services and SUD services, knowing that that's kind of critical in rural communities. What that will look like, we don't know yet. But we will be driving to ground in earnest. Other Medicaid provisions, I shouldn't have missed this one, but there are some changes that take effect in October to refugee, asylee, and other non-citizen adult coverage in Medicaid, restricting federal funding going to certain non-citizen groups that are lawfully present. So I want to be very clear to articulate these are not undocumented immigrants. These are individuals who are lawfully present, who the Medicaid program has been supporting. And we anticipate it could be upwards of 30,000 individuals in Washington. We're still trying to figure out exactly who. Again, there's no additional supplemental details from CMS at this point. So we're trying to figure out who the coverage groups are in the dark a little bit, but this is going to take effect pretty abruptly. So will be kind of the most immediate coverage change that we see as a result of the budget. And then some other provisions here, none of which we are eager to implement, but all of which we are required to under the federal budget. With that, I'm going to pause. We have a lot more information in the deck that I shared about kind of background on the Medicaid program, some information on the coverage impacts in the individual market, a little bit more detail that I didn't go through on some of the federal budget provisions. But I know it's a lot, and I know you're running low on time for your meeting. So I'll pause. If there's time for questions, happy to stay on for a minute. Otherwise, I'll turn it back over to my colleagues.
Please, questions for Evan. Malika.
So it seems like maybe you're the more appropriate person for me to direct this question to that I asked earlier about what are some of the immediate impacts that will be occurring for rural hospitals? We're hearing a lot about how folks have only got the capacity to be able to maintain for like 2 more weeks and, you know, all of these different things. And then it sounds like there isn't even an RFP. And we've heard that there's $50 million available, but if folks don't have access to that, very much like if people have health insurance but no access to healthcare, it doesn't really mean much. So can you help us understand a little better, like how quickly this could turn around for places that are running on a razor thin margin?
Yeah, so the provisions in the federal budget, for the most part, I wouldn't anticipate seeing effects for rural facilities or for hospitals in the immediacy. What the 2 major things that are going to impact the kind of bottom line for hospitals, and I think, again, like we can all expect, it will acutely affect rural facilities and those that have a very high proportion of Medicaid clients that they see, are going to be the eligibility and enrollment provisions. You know, if individuals, you know, if 200,000 people become uninsured in Washington that had previously been receiving Medicaid, and those individuals go receive services at hospitals, and we would imagine that it's going to be higher acuity services, more emergency room visits, because they're not going to be getting preventive treatment because they can't get that paid for if they're uninsured, that you're going to have more facilities that are going to have uncompensated care, charity care, possibly being able to get, you know, some reimbursement, but might be foregoing reimbursement for services that they had historically been getting paid through the Medicaid program. That's going to have an impact. And then the state-directed payment provisions, that hospital safety net program, once that starts to wind down, will obviously also have a very acute impact on hospitals. The majority of those provisions, with the exception of kind of work requirements, if we are forced to implement that in, you know, by the end of 2026, you would start to see coverage changes in 2027, and that could have an impact on facilities starting in 2027. So you're about, you know, a year and a half out from starting to see kind of the trickle down. Same thing with 6-month redeterminations, which could impact enrollment. The state-directed payment provisions, those don't take effect until 2028 and beyond. So you won't see the major impacts of that till 2029, 2030, et cetera. So there's a little bit of time, not much, but there's a little bit of time where we probably won't see acute impacts for rural facilities. On the rural transformation funding, that funding does start to flow in October of 2026. So if Washington State is approved, and we will be submitting an application, I think we've been very adamant about that, and the governor's office has been very adamant about that, which we're working on. But if Washington is approved for that funding, we would start to see funding coming into the state that could go out to support rural facilities beginning in 2026 before the end of the calendar year. But it won't be a panacea. We know that money is insufficient to backfill the totality of losses that we would anticipate as a, in terms of the total impact of HR1. And I should have noted, but if the state is approved for that rural transformation funding, the bare minimum that we would receive is $100 million per year for 5 years. There's a lot of discretion within that budgeted amount that could exceed that up to 150, 200, $250 million per year. But we wouldn't know until we get any CMS approvals. Malika, does that answer your question? I know there's a lot of context. But...
Yes and no. I mean, I know there's just so much that's unknown. It's just that I know that a lot of places around the state are like, you know, we aren't going to be able to make it, like, and even to when these things might kick in. So I was just trying to get a better understanding of, from your perspective, the logistics of it. So thank you for that part of the answer. And it's not your fault that you don't know the other stuff. So thank you.
Yeah, and you know, we know this isn't happening in a vacuum. So I think part of the context here are state budget conditions and reductions that we're in the process of implementing as an agency as a result of the state budget from this past year. Other changes that are happening with grants and federal guidance that may be impacting other funding streams. But when it comes to Medicaid reimbursement, related to HR1, related to the federal budget, those impacts won't be felt for a year and a half to 2 years, I would anticipate. But again, that's, it's not happening in a vacuum. So we understand there's a lot of anxiety right now, I think, from everybody in the delivery system, and particularly small rural providers.
Thank you.
Evan, thank you so much for your time today, and thanks for going over that summary. I had just one quick question. The Rural Health Transformation Plan, is that something that would be developed and submitted along with Washington State's application, or is it something we would submit if our application was approved?
It is part of the application. So it is a requirement of the application is to have a rural health transformation plan. And as I noted, the timelines we're working on for implementation or for development of that plan are very abrupt. We anticipate we're going to have to start with kind of what's the outline, what are some discrete mechanisms for spending over the next couple of years, and that there's going to need to be a need to fill that in over time. So I think we're trying to get to the most robust product that we can provide over to the federal government by whatever deadlines they set within the next 4 months, which is not a lot of time to develop a true kind of comprehensive plan for solving a lot of the challenges we have in rural communities. We know that. We are working towards some form of information gathering. Some other states have pursued formal RFIs. I think we're contemplating whether that makes sense in the timeframes we have. But some form of information gathering, and I would imagine we will be finding ways to gather information from the behavioral health community, in addition to hospitals, providers, tribes, others, community health centers, over the next couple of weeks into a couple of months to round out our perspective of where are their needs, what are the biggest needs, how can we get money out to support those needs. But yeah, Tony, the plan is required to be included, but it's a lot. So.
Okay. Yeah. Thanks so much. You kind of saw where I was going with that answer. My subsequent question about how to get, this committee either, an opportunity to respond to or provide feedback on any plan. It sounds like there might be some kind of statewide communication going out. So thank you so much. I just noticed the time. We only have 3 minutes, but Evan, thanks so much for sharing your time today and sharing some of your expertise on that, and appreciate you being here. Oh, there's a question from Representative Mondrez.
Thank you. Yeah, this is Representative Mangeras. So it's really a question for everyone that's presented today, or some ideas. It sounds like in the Medicaid, the reduction that's going to happen. You're right. The exemption is going to be probably for individuals that are in substance abuse recovery. They're in treatment. And it's wonderful to hear all of the testimonials today from the success stories. It's incredible, very wonderful. But tell me what policy changes we need to make. I mean, I still think our policy in the state is we're waiting for an individual that has a substance abuse disorder to decide when they're ready for treatment. And I think we need to recognize that if they're under the influence of this substance, heavy use particularly, they are not in a state of mind to make that decision for them. And that we need to move closer to involuntary treatment for the benefit of that individual. For example, I'm over here in the Yakima Valley, it's over there in King County. You see these people that are almost comatose. I mean, they're under a drug-induced state. What policy change do we need to make to take those people to the hospital, whether they choose to or not, to take those people to the hospital and truly help them detox and get them into treatment that they will thank you for later. And of course, that treatment, they'll be exempt from this Medicaid, pay down. Will be able to get their treatment paid for. I just see that's got to be the policy direction that we need to go to in the state of Washington. We can't wait for them to decide, okay, we have to help them get to that decision. I welcome any of your comments from anybody on that policy change that I think we need to make.
All right, we are at time, Addie. Go ahead and make your quick comment if you would.
My quick comment is I think there are a lot of people who are in the situation you described who have presented at various places asking for help, and help was not available to them in that moment, and the opportunity was lost. So I agree with what Caleb's saying. We need to make evidence-based substance use treatment services available on a walk-in basis fully throughout the state before we pursue carceral or civil commitment type approaches. We don't have adequate treatment infrastructure in this state as it is.
Rep. Managers, you've got a bunch of links in there for folks that you want to may reach out to. So
yeah, Representative, thank you so much for your comment, your question, and the prompt to this committee. We are over time. Addie, thanks for your comments. Malika, if you wanted to share something real quick, please feel free to. I don't want to stifle the conversation, but just noticing the time for everyone that might have somewhere else to go. Go ahead.
Sadly, we know that forced treatment, it doesn't work. We have lots of evidence that shows that doesn't work. And to Addie's point earlier, we don't have the infrastructure, and the current infrastructure that we have now is frankly under threat by the policy changes that we just were speaking about on the federal level. We've never had enough access to treatment for all the people that experience substance use issues. And we don't even have a good handle on how many people that is because folks are so stigmatized and they don't ask for help. I do look forward to getting to know you better, Rep. Manjarrez, and I look forward to finding solutions and creative policy solutions. But unfortunately, that approach, we've done that for a long time, and it has gotten us exactly where we are now. The forced treatment, making people scared to engage in services. But you told me to keep it short, Tony, so I'm being quiet now.
That's really helpful. Thank you. There's a lot of comments in the chat. And so I think this is something we can make time at for a future meeting, especially given the amount, I think there's a lot to unpack here, and I'm glad you brought it up, Representative. And we can set aside some time in the September meeting, and maybe as part of like the SURS plan monitoring conversation that we wanted to have, like how best can SURSAC monitor and inform progress made towards the SURS plan, and we can embed it as part of that conversation. So I just want to close out the meeting, but thank you everyone. for your time today, and thanks for this really, the great conversation today, and especially this great question that you asked at the end, Representative. I think this is a good opportunity where SURSAC can talk more in depth about it and provide thoughts. We obviously have a number of different thoughts in the chat, and some research and some evidence, and so we can set aside time in September. Thank you so much again. Apologize for running such a close agenda that we run out of time at the end, and we'll try to make sure there's more adequate time in the future, and really appreciate everyone being here today. And as always, appreciate those providing direct services in the community to everyone that's at risk of overdose or in need of support, in need of services. And we'll talk again in September.